Assalamualaikum warahmatullahi wabarakatuh. My name is Desi Trasuti from class 2B. Now, I want to speak about patients with genetic disorders. A. Down syndrome. I usually due to the development of an extra chromosome. 21 trisomy means that there are 3 chromosomes instead of the usual pair. The result is a total of 47 instead of 46. The other's mother 35 or over. The more likely the fetus can develop chromosomal trisomy 21. Down syndrome may also be caused by translocation, the abnormal chromosome break, rearrangement, and fusion in a different order. This cause might be inherited or unknown, but maternal age is not a factor. 1. Symptom: moderate to severe mental retardation and abnormal skeletal development are present at birth. There may be other congenital abnormalities. The head is small and flattened. The tongue obtrudes from a small mouth and mandible. The eyes have a lateral upward slant and apicanthal fold at the nasal angle. The bridge of the nose is flat. Muscle tone is diminished. Extremities shortened with the bird, square and flat hand and feet. 2. Family guidance. Initial parents' reaction may include shock, denial, frustration, hostility, guilt, depression, and fear of the future. Listening, support, and communication are needed to provide guidance and help with feelings. The goal will be help parents emotionally adjust, cope with problems, and plan constructively for the long-term needs of the child. 3. Placement. The child with a permanent handicap, limitation on learning ability, or impaired physical development will need comprehensive health care, a supportive, nurturing environment, and the love and guidance of responsible adults. The parents might need to consider institutionalization versus home care. Although children with Down syndrome have a greater potential if given loving care by their own family, the physician and nurse assist by discussing advantage or disadvantage, explaining facts, answering questions, and supporting parents as they make their own decisions. For special health needs, prevention and early treatment of frequent skin and respiratory infections, atrial or ventricular septal defects, patents declus arterius, or strabismus may need surgical correction. Dental abnormalities may impair nutrition and require additional dental care. Leukemia is of a higher incidence in Down syndrome children. Physical care. Poor muscle tone and weak sharks require slow feeding and avoidance of tearing. Proper support and alignment are needed owing to flaccidity. 6. Learning. The retarded child will be much slower to learn self-care, such as feeding, dressing, and toilet training. Mimicry, repetition, and patience promote successful training of over time. 7. Family support. The family will have many adoptions because of the child's prolonged dependency. Siblings need adequate parental time and attention. B. Phenylketonuria. A genetic disorders or phenylalanine metabolism because an essential enzyme is missing. The phenylalanine contained in all natural protein foods cannot be converted to tyrosine. The accumulated serum phenylalanine cause mental retardation. 1. Diagnostic test. A. Guthrie test. B. Urine testing. 2. Symptom. A normal newborn becomes dull and lethargic by 4 months of age. Moderate to severe mental retardation will result if untreated schizoid, hyperactive, hypertonic, irritable behavior, possible seizures, and eczematous lesions may occur. 3. Diet. Severe restriction of phenylalanine for at least 6 to 8 years. The diet is revised with the growth of the child and based on weekly monitoring of blood levels. A. Essential amino acids. B. Solid foods. 3. Free foods. D. Foods prohibited. C. Cystic fibrosis, a genitally transmitted disorder of exocrine gland function causing chronic pulmonary disease, pancreas deficiency, and high sweet electrolyte levels. 1. Pathophysiology. Chronic pulmonary disease results from thick mucus plaques of bronchioles causing over-distended alveoli, chronic infection, and fibrosis of lung tissue. The chronic obstructive lung disease may lead to cor pulmonale. 2. Diagnosis. Positive swab test, absent pancreatic enzymes, from duodenal secretion, pulmonary change on X-ray, and family history of the disease. 3. Symptoms. Fault, fatty, frequent bulky store, failure to gain weight, progressing to malnutrition or emaciation. Respiratory symptoms as choke, dyspnea, cyanosis, or recurrent infection, taste to the skin. 4. Nursing care. Pulmonary involvement is treated by the same measure as discussed under emphysema. Parents are taught to do cupping and clapping, choking, deep breathing, postural drainage, and aerosol therapy. 5. Nutritional needs. Pancreatic extract replacement give with each meal high protein, high caloric, moderate fat diet, and double dosage of a water soluble form of vitamins A, D, and E are recommended. 6. Long-term outlook. The degree of pulmonary involvement and effectiveness of pulmonary therapy measure determine the eventual outcome. Children should attend school and participate in sport or other activities as tolerance permits. D. Sickle cell anemia, type 5. A homozygous mutant gene affects every erythrocyte synthesis with defective hemoglobin S instead of normal hemoglobin A. 1. Pathophysiology. As a result of hypoxia, an infection, or an episode of acidosis, the hemoglobin S molecules distort the erythrocyte into cycled shapes. These cells clump and occlude capillaries with resultant ischemia, infarction, and necrosis to distal organs or tissue. 2. Diagnostic test. Peripheral blood smear or sickle cell preparation test will demonstrate sickle cells. Hemoglobin electrophoresis will differentiate trait from disease. 3. Symptom. During a crisis of sudden onset, the symptoms vary with location of occlusion. 4. Nursing care. A. During acute crisis. B. Family should be taught. C. Screening to identify A. Celiac disease. Malabsorption syndrome due to permanent intolerance for gluten contained in wheat, rye, oats, and barley. The disorder is hereditary, but the mode of genetic transmission is unknown, causing low hemoglobin and anemia in older children. 1. Diagnosis. Physical exam, jejunal biopsy, 72 hours stool collection for fecal fat, and later a beneficial response, a gluten-free diet. 2. Symptom. Onset of food malabsorption at some time after foods are introduction into the diet. Stool are large, bulky, full-smelling, greasy, and poorly formed. 3. Dietary management. Gluten-free diet. Eliminate wheat, rye, oats, and barley. All other foods are primitive, including fat and starches. Uh, I think it is enough. Thank you for your attention. Assalamualaikum warahmatullahi wabarakatuh.